There we go.
Thank you.
Welcome.
Yeah, can I have a next slide, please? Yeah, with respect to volume and the timeline when we started these screening, we usually screen about 165,000 dried blood spots, including repeat screens in Illinois. And we initiated Krabbe screening in December 2017, whereas it was done in June 2019. So we are screening these two disorders for some time. Can I have next slide, please? The way we screen ALD, basically measure C26 LPC biomarker, and this lipid is extracted rapidly in methanol, and we use HPLC via negative ion mode. We analyze or we quantitate this biomarker using QSI 210MD screening system. Next slide, please. As I said, we initiated ALD screen. Yeah, so with respect to Krabbe screening, we measure GAL-C enzyme activity in dried blood spot using ultra pressure liquid chromatography method. And we use TQD mass spectrometers. We do multiplexing. We analyze total of 7 enzymes in this assay. And the way we screen GAL-C activity, if our initial activity is less than 16% of the batch medium, and this batch medium is basically average, this batch median is coming from different plates on the same day, either on same instruments, on different instruments. And if our activity, initial activity is less than 16%, we repeat the specimen and in 5 spots, and then we calculate average of those 5 spots batch median activity. And if it is equal to or less than 13, we call this abnormal GAL-C activity, and we send out this specimen for second-tier testing to PerkinElmer, and this includes cytosine 30 kilobase deletion and GAL-C sequencing. Can I have next slide, please? With respect to GAL-C, the way we call out abnormal specimen is once we have GAL-C activity less than 13%, we get a cytosine and 30 kilobase deletion analysis result. And after getting these results, we don't release it, so at that time, until we get sequencing results, the infant result is pending. And once we get sequence result, we interpret the sequencing result according to the send out lab, and we either call negative if cytosine and those levels is associated with pseudo deficiency allele. If we detect VUS or any deleterious mutation, including pathogenic mutation, we call this a positive screen, and we create a case. This way, a specialist can see the baby and decide the next step in their protocol. And if suppose cytosine results are elevated, and at this moment we have 8.7 nanomolar cytosine level, so if it is above that level, we call positive, and we refer baby immediately for further follow-up as a suspected infantile case. Can I have next slide, please? And this is the summary of the data we have. So far, we analyzed, we screened 542,903 specimens. And out of that, we had 336 screened as GAL-C positive screen. And these screens were sent out for second-tier testing. As we can see, in our state, we send all specimens for sequencing analysis at this moment. So if you look at this data, most of these specimens, about 62% of these 336 specimens had pseudodeficiency alleles. And their cytosine level was less than 2. As you can see in the column, greater than 2 or less than 3 nanomolar, it shows as a 0. Because these have pseudodeficiency allele and cytosine levels are not elevated, we call these as a negative screen and we don't create a case. And then there are 2 additional categories shown here, and this include specimens having either VUS or one pathogenic allele or heterozygous 30 kilobase deletion. In this case, we had few cases, I should say few specimens, few infants having greater than 2 nanomolar cytosine, but less than 3 nanomolar. And this include 5 having VUS deletion and 7 having either heterozygous 30 kilobase deletion or one pathogenic allele. In both cases, these babies were referred and the specialists decide further action on these cases. And the last 2 categories are related to either possible late onset or infantile Krabbe, and this is shown in the next slide. Here I have described the detail of late onset suspected cases and IKD infantile Krabbe suspected cases. And in the first category, we had cytosine level greater than 2 and less than X. And all these have developed any disease until this time. The next category of 3 cases where a cytosine level was elevated, and first 2 cases, 10 and 35 nanomolar cytosine level, they had pathogenic alleles and their cytosine levels were elevated, and these babies, these infants are transplanted. And the third case, which recently we detected, and this had cytosine level 55 nanomolar, and at this point, the parents still have not opted for transplantation. And to my understanding, there are no symptoms at this point. And I think one slide was missed earlier, which had ALD data. If you can go back to that slide. Yeah, this is the one. Thank you. So with respect to ALD, so far we analyzed about 307,000 specimens, and out of them, 79 were called as borderline, and 18 of them were called as positive. And our positive cutoff is greater than 0.28 micromoles. And whereas our borderline cutoff starts from greater than 0.18. Out of these cases, 16 were diagnosed, and 5 of them are presumptive XALD, and 2 of them had a Zellweger spectrum disorder suspected cases, and there are 6 female carriers, and 3 of them are belongs to other category. And out of these 96 abnormal call-outs, 64, and there are still 13 results are pending. And the last slide, which basically is acknowledgement, where I thank for all the staff members in the lab who are doing the analysis and who are involved initiating or validating this method, as well as staff in Springfield, the staff who are responsible for follow-up care. Thank you very much.